can show this on my phone.
Hello.
Okay, there you go.
Hello, Christina. How
Hi,
are you?
very good. Can you hear me well?
Yeah, can you hear me?
Yeah, very good. Thank you.
I'm so glad to have you. Like before, when I was reading about you in the bio, I was like amazed. I was so glad that you're with me. So thank you for doing this with us. I will
Oh,
let you introduce yourself a little bit before we start.
okay. I'm Christina Kang. I'm here in Miami Beach, Florida, United States. I am a speech language pathologist specializing voice and upper airway issues. So I basically tell people I help people with anything from neck up. But I am a trained soprano classical singer, and that's how I got into voice pathology. So right now I'm the owner of the Voice Forum, where I provide international voice habilitation and, if it's necessary, rehab. Um, Last patient was in Singapore, so it's really fun helping people internationally.
Yeah, I love your page and your website. Guys, if you don't follow the forum, you should go, the voice forum, you should go and check it now. Christina posts amazing things.
Oh, thank you.
Christina, we go straight into the topic. I know we both have our clients, and I want to ask you, how do you evaluate muscle tension dysphonia? We know that it's the most common voice disorder in most laryngology clinics.
Right. No, the patient have had a venous stroboscopy, ruling out any kind of like laryngeal pathology, ruling out any neurological disorders, even autoimmune diseases. There's so much to look at. So it's really optimal for the pathologist and the laryngologist to evaluate, but obviously that's not the case in many situations. So I am getting a patient referred to me to evaluate for muscle tension dysphonia, I have to make sure that I communicate with the person who's referring them to me. And then,
Yeah.
of course, there's a primary muscle tension dysphonia where people have no pathology, but they're just having a really tense, a severe harshness and vocal strain. And there's secondary. If there is a pathology, then the muscles compensate and add on. They develop a what we call compensatory muscle tension, trying to bypass the dysphonia, but they don't. Of course, they don't know they're doing that. So you have to rule out primary versus secondary muscle tension dysphonia.
Yes.
And also, you know, people like to think that muscle tension dysphonia is functional, meaning it's we take it as very psychological, but I don't like to do that because that's putting the onus, the blame on the patient without really knowing the background and not really seeing them and hearing them. And so apart from the laryngoscopy, you have to do the stroboscopy to really rule out the pathology. A lot of times people say, oh, that's a nodule, but it's really actually a cyst with the reactive lesion. Then that is really, they need to talk to a surgeon. Not, you
Yeah.
can do voice therapy. All that evaluation with instrumentation, of course, is very important now. When I sit down with a patient, really talk to them, really try to see what's going on in their life, what happened around the time they started noticing the voice problem, if they ever had this kind of problem before. Sometimes they think that it's happened out of the blue, but I like to think that the barrel has been filling up for a long time. Something happened and just kind of flow over. So I provide them with specific analogies. It promotes them to think about their life and their life situations that may or may not have contributed to the problem. But now, when I look at the person, I look at how they breathe. A lot of people don't think I breathe just fine, but you're sitting and listening to me right now. You don't really have to engage in detailed coordination of the breathing with the laryngeal muscles and the resonatory system and whatnot. But a lot of times they come in with a very high chest, and it's a very anxious time right now, And something I learned over many years is that you don't have muscle tension just in the, they may notice it there, and symptomology may manifest there, but really muscle tension is not just the throat; it's head to toe, in my opinion. And then so I like to breathe, and if they're breathing really shallow and with the stomach tight, and if I observe that, I explain to them that, you know, this is what you're doing. I show them that I exhale all the way out, and I start talking with no air, and then they can hear that I'm having attention too. So having them see and observe what normal person can become with no breathing. So I check out breathing, and then also that's evidence-based, because, you know, in neurosciences, the go-to to, you know, reduce stress in the fight or flight sympathetic nervous system, right? And so if somebody's coming with a lot of anxiety and muscle tension, I really need to look at how they breathe. And secondary, if they're having any kind of like hypernasality, they're having hearing issues that are making them talk like, you know, back of the throat. And I asked them if they have ever had any trouble getting their volume out, you know, pitch range out. And a lot of times people have never thought about their voices that way until they actually start to have trouble being understood and whatnot. So it's a complicating procedure where you just have to sit there and listen and really see the person. And there is no way to say, you got to do this, you got to do that. And yes, a lot of people do the acoustic analysis and, you know, aerodynamic analysis. Yes, I do that. You know, it can help. And in our country, you do need the objective evidence for insurance building and stuff like that. I do, but
same here. Yeah, same here in Lebanon. We have to do them. We do like objective and subjective voice analysis. Here we have a scale called GRBAS. It's a scale that it's a subjective analysis of the roughness, the gravity, all the characteristics of the voice. And we do, of course, the aerodynamic measures. We do the maintained the long I don't know what you think about it. We also do
what we do, of course, you know, if you had an instrument such as phonatory aerodynamic system, I put a mask and then they blow, we measure the airflow with voicing, without voicing. But the way you can do this is have them take a really nice inhalation, the letter S, as long as they can go. You measure that, and then you have them do that again on letter Z. And then you compare S to Z ratio, and it kind of tells me if the coordination of respiratory and phonatory system. And so that's something I can do without any equipment. And yes, long as possible, you know, that's maximum phonation duration. It's beneficial. So we talked about acoustic and aero. Yeah, there's CLS, which is
I was saying maybe auto evaluation or questionnaires. You also use that. I don't know.
Yeah, I mean, the questionnaires, patients have to like their voice handicap index. There's the long version, and there's voice handicap index, the 10 question version. I use intermittently. If somebody's having really good awareness of their voice and their singers and whatnot, yes, I give them singer handicap index as well. And there's dyspnea index. You do have to ask about eating disorder, how they breathe, chronic cough, and the laryngeal hypersensitivity questionnaire, Dr. Vertigan in Australia, that really helps in seeing if they understand what they feel. So I don't like to use the word idiot, but are they really vocally dumb? Like really, they have no awareness. And so having the questionnaires and seeing how they answer gives me an idea of where I can start with the person. And so acoustic aero perceptual analysis, GERPAS I use a lot. And then in our clinic, since I started doing research, more CAPE-V, consensus auditory perceptual evaluation of voice. In a paper, you have to mark and then you have to measure it with the ruler, and like that. But besides that, of course, I assess the paralaryngeal muscle tension. I mean, I think digital manipulation is really beneficial for diagnostic purposes. I have kind of moved away from using that for therapy because I was doing more pain rehabilitation training, I found out that people were using massage as a pain behavior. They were just going and doing it. And it's kind of like putting a Band-Aid on an ulcer. They're not treating the ulcer, they just keep putting a Band-Aid on it, and they're really not looking internally. So, so that has, ever since I started doing the research on muscle tension dysphagia, I wanted to know why people were the symptoms, and muscle tension just doesn't come out of nowhere, right? And you have, in order to understand what the person is like, I started studying pain rehabilitation. So they have a lot of how the brain learns pain, emotional, physical. The brain doesn't discern at all. And so I like to look at if they're holding that kind of pain behavior. Some people like to lock onto like locations. I gotta release this. I gotta do this muscle. I gotta, like, they like to look at like little nitty things, but I want to help them look at themselves from head to toe holistically, so they don't no longer have to have that also. You know, they no longer have to keep putting Band-Aid on it. And people with muscle tension, dysphonia, dysphagia, even disc breathing, a lot of people are tense when they breathe, and you can't help them just with the breathing, just with the throat, head to toe. So that's, you know, we talk about evidence-based this and that, but ultimately you can know all the techniques in the world, but if you can't see the person and hear the person, the technique it doesn't work.
And it also should be adapted to the environment, to his environment, to if he can apply the method or not.
Right.
Right.
And then, you know, I'm about to give a lecture in a month for speechtherapypd.com about how to release muscle tension. It's a lab, and I had to think about it a lot. And you have to see how we look at the person, not what to look at. You know, so when I CFI, I'm like getting all these technical knowledge, and I'm like, do straw, do this, do that, and then they'll do it, but they're like not letting go of tension. So until I started to see the person, I wasn't able to really truly help them. Once you start to see the person better, like really understand the whole picture, then therapy to be a session goes down to 4 or 5 at max. So it makes therapy really efficient. So I think more experience I got, less the therapy session frequency got. Not good for the money, but it's better for the person. So evidence-based, lately I've been going a lot for vegetative function, because I found out that people can draw or all the exercises like really well with tension. So you give them a little bit of water. Easy as gargling, right? They can't do it. They start choking because holding their breath and all that. So instead of telling, do this, do that, I just tell them, gargle, make a sound, make a strong gargle, and then brain figures it out. That is the motor learning. That's evidence-based. So many things. You know, I like people to look at the vocal techniques, the voice therapy techniques.
And so now, if you could tell us more about the voice techniques that you use, or the therapy methods that you use that you find the most efficient, that could help us as like people who maybe don't have enough experience in voice therapy, that we could use and that could help us in our therapies.
Okay, so of course I have to have the patient in front of me to see what's you know, what I can apply. But something I tell people all the time is, you know, when they breathe, you know, people just tend to breathe or whatnot. And first of all, teach them the diaphragmatic breathing, where the belly comes out because the diaphragm is going down, pushing down on the gut and inner. So you explain to the patient that your diaphragm has to go down in order for you to breathe well. Is you don't hold any tension, and none of the strap muscles engage to, you know, once you get the breathing, you tell them, whenever you take that relaxation breath, what you feel going through your nose into your throat is a restart. Is your breath will tell you how to release, because relaxation breath is relaxation. You know, you can't breathe well if you're tense. So relaxation breath, and I tell them memorize how great it feels to have that easy breath going in, right? The easy breath going in, and keep it like that every time you start the exercise. So if I'm giving them a straw phonation, they like, ooh, they try to blow, and then I tell them to suck in through the straw. Notice how cool the air is. The throat feels nice and open, relaxed. Remember that, and now add whoo in the straw, and inevitably they go oh. So okay, all right. So did your throat feel like that beautiful inhalation before, or did something change? And yeah, I felt something tightening. So that's what we don't want to do. So I keep having them and sometimes they're so busy and keeping the throat relaxed, they forget to phonate. Like no sound comes out. Great, that's a progress. Your brain is saying, and you know, water was great, but sometimes I would have a straw in here, you know, straw in here, and then they blow beautifully. And I've seen everybody blow water beautifully, but as soon as you tell them to add sound, woo, there's no bubble. Like, when it knows, I said, it's no, you did not put a sound. So what changed? And then so I'm trying to get them to increase their kinematic proprioception, because if they don't realize it, then they won't make that progress. You know, and that's why I like to do exercises where I'm not actually going in and shifting. In the beginning, when they're that tight and they're totally confused and they don't know why they're seeing a speech therapist when they can talk, I go there and I massage, and then they can see, wow, something is different. You know, I do it a lot for buy-in. I rarely do that for consistent therapy. And so, and another thing is, we talked about this and then
Yes.
tell them,
Yes.
that's a option. It's easy, but as soon as you want to put the z, what do you feel? And then they do it often enough, and they go, oh, I feel something. You know, like something's tight, and yeah. So you don't want to do that. You know, if you feel like it's about to get tense, just stop. Tell the brain, I don't care, and then take a breath. Reset. Every breath is a redemption. You get another chance. You know, that's many chances in a lifetime. You know, so. And I help them coach through that. And then after they start to feel like, oh, I do this, whenever I'm tense, my shoulders go up, and they start increasing their awareness. And I know a lot of therapists don't do breath work. They feel like it's a waste of time. But for me, I do it because science tells me when you relaxation breath, your stress down, sympathetic system decreases, and parasympathetic comes up. So person gets to be relaxed in general, and then you teach them voicing on top of that. To me, that's like a no-brainer. And a lot of times I don't create voice exercises. I just have them breathe in and out through the straw. The straw acts like a traffic control in a very natural. Doesn't have to get confused or excited or tense. You just put it in your mouth and then just breathe in out through the straw. Long exhalation, relaxation, inhalation. And I tell them, you do not breathe through sucking in through the nose or the mouth. The breathing is done completely with pressure. Long, try to leave everything alone and just enjoy what's happening without you trying. And then after they breathe in and out, and you do have to coach them to release the stomach and do all that stuff the SLPs know how to do, or voice teachers. And then they feel that relaxation. I can visibly see shoulders go down, and then I say, now add whoo, whoo. And a lot of times they'll go, oh, I got tight. And so make them the therapist. So every voice, I'm not fixing anybody, I'm teaching them to be a therapist. So that's much more efficient and more power to the patient. And that's what I want. When I was a voice patient myself, I did 3 years. not every day, you know, but first 2 times I didn't know why I was doing what I was doing. There wasn't an explanation. I loved my therapist, you know, but and I was a very stuck-up opera singer. I thought I know everything about voice. You know why? You know you don't know anything about singers. It was bad. So I wait. So the third time I had a voice problem is because I was in an SLP program, and then I had severe muscle tension dysphonia with bad reflux. And graduate school was horrible. I never got sleep, you know, and so I was super tense. And my therapist was my voice, and so I got to understand. She explained, and I realized that I didn't do therapy before because they just gave me an exercise, but I didn't buy it. Did it, but I don't know what I changed. To be their own therapist is probably the rewarding aspect for me.
Yes, we should be convinced ourselves with the exercises that we do before we give them to the patient. We should always try them on ourselves, see how it feels, the vibrations, how it feels for us, and then we do it on the patient. So I totally agree.
So starting in August, I'm gonna be going back to like full-time private practice, and I decided to really train people who wanna be voice therapists. And I realized a lot of people out there who wanna be voice therapists don't have a good vocal function. They're talking in glottal-fry, or like they think they have a good technique, but a lot of times they're very hyper nasal. I want to teach voice therapists or even voice teachers to have a good vocal function when they're talking, so the singing can be easy, or doing therapy all day long. I see 12 patients a day, you know, and then they don't get vocally fatigued as much. That's the direction I want to go to. And therapy is interesting. People say, how can you do the same thing every day? It's not the same every day, because I'm seeing people every day. Everybody individual, everybody. So if you know anybody who wants to work on their voice, I'm here. I can help people without pathology to have better. Did I ask questions?
Yeah. I just go ahead.
So when the patients don't understand the potential of their voice, how good it can be, if they can do it, I have them do or that lip trill, that tongue trill is a voice they can have. You know, you can't get there. And when they're doing the lip trill, tongue trill, you're not just doing it just for fun. It's for them to understand, I can get there. I can, a really good lip trill versus, you know, hyper, you got to help them find their Goldilocks zone, their Zen spot. And that comes in every voice therapy. But lip trill, tongue trill, if they can't do any of that, even doing that or gargling the voice, any vegetative function, get them to the body can do before you give them exercises, or they will not come back, or they'll start beating themselves up. So be at the patient's level. I think that is evidence-based.
Yeah, for sure.
Yeah.
We just want to ask the people that are watching us if they have any questions, or if they would like to know something more about the subject. You can write in the comments, and then Christina will answer your questions in case you have.
Sure.
Christina, I have a small question concerning breathing. We work on to help the patient see more the abdominal breathing versus the upper breathing. So would you do that, and do you still do that?
Yeah, of course, totally. So I'll get up and show you, okay? So more breathe, they go do that, right? Their stomach is in and they try to do that. But really, when you breathe, you're supposed to relax the tummy so you can go out, forward, sideways, back, and even lower, because your pelvic floor is also a diaphragm. So when they're all tense in their hips and whatnot, they can't really relax to breathe. And so I have them like sit on a ball, roll their hips, and then I tell them, imagine if I'm too loud or I'm too like noisy, just tell me to shush. Shh. And then they realize their belly goes in. Shh. And then their belly goes in. And then oh, good. So that same belly contraction you felt when you feel like you can no longer do it, you need to take a breath, those same muscles Let them go. Relax them. Let them go. And it's the hardest thing for them. This is perfectionist. They're like, I got to keep it in. So if I can convince them to relax that even a little bit, they realize the breathing is not as hard. It's not a lot of effort. We go in that direction. So that comes. The belly is still happening. Mom, 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 mom. Anything we do voicing task with, we have to start doing it with the same belly motion. And then, of course, it's not just the belly coming out, right? It's just think of it as letting air in. If you let air in, it means you got to give up control. And that's really hard, people with anxiety or perfection.
Yeah.
And then I go.
Thank you so much.
No problem. Somebody asked
We also have a question. Yeah, you saw it. Yeah, any tips for treating chronic refractory cough for the fresh SLP who is asking? So if you could answer the question.
So don't have so much time, but I can tell you that chronic cough is also looked at as chronic pain. I told you that the brain learns pain, right? Mental, emotional, physical. The throat is so sensitive because it has to protect your lungs. There's 3 jobs for the throat: protect, protect, protect. It's not swallow, eat, breathe. It's protect, protect, protect. So many sensory nerves in there, talks to the brain. And with reflux or allergies or whatever, if a person has a tendency to develop that sensitivity more than others, it becomes hypersensitive. And which means the brain has learned to look for sensitivity. And in neuropathic pain, we have something called paresthesia, where there is irritation and there's nothing there. Paresthesia, the brain has a different way of looking at stimulation. So it made the throat hypersensitive. Okay, so what's wrong with that? Well, sensitivity, motor function go hand in hand, and the motor gets all the info from the sensory, like a twin that was born a second earlier. The sensory is giving all the wrong information, and throat is like all freaking out. It's constantly fidgeting and like kind of like a tennis player, like around the court. So you give them that you give that information to the patient that the brain has learned a very sensitive way to observe stimulation. Now your motor response, which is cough, is over responding because it's getting the wrong information. So and then have them understand the trigger. What are they feeling in their throat that makes them cough? Is it really the throat? Is it the chest? Most of the time it's right here. Tickle, dryness, mucus, phlegm. I've heard it all. Ants in my throat, or just like even listening to somebody cough, they'll cough. So that's all telling the brain pain, 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 And so I tell them, you can't stop the brain from doing something. If they want to cough, it'll cough. But just because you feel it doesn't mean you have to react. Okay? Then they go, well, I can't help it. Well, then give the cough something else to do. Instead of coughing, throat clearing, same thing. Both are the same reasons. Swallow. Now, not just that kind of swallow, real deep tissue massage inside the throat. So 3 ways. 1, put hands together, tuck chin, and push your hand, and you swallow really hard. And that is a very deep tissue swallow. Now, you get driving, you can't do that. So I tell them, tongue out, masako, and swallow hard, right? So that in a meeting, then tongue to the roof, push, 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 as a swallow. Keep doing that. Trigger coming on, even if they hear somebody else throat clearing or coughing. You just got to calm the brain. And that is how I help with my chronic cough patients. Of course, if that behavior strategy helps some, but not all the way, so sensitive, then you got to have neuromodulators like gabapentin, amitriptyline. The doctors can prescribe that. Only side effect is that they're very drowsy. But I like to do the therapy first, and then just at least get to 60% efficiency, and then neuromodulator, bam, nip it. That's a lot of time. You just got to have neuromodulator to begin with, and then do the therapy. I only...
there are just...
Lax box.
What?
First use lax box under... Oh, of course, yeah. The lax box, I don't call it lax box, I just call it water bubbling with, voiced semi-occluded vocal function, SOVT, with water resistance. That's what I've been calling it for 10 years. And then somebody called it Black Fox. I'm like, what? Yeah, you know, this is great. More water you have, more resistance you have is like more workout, right? But having too much resistance also backfires. Having just good middle ground with not a lot of tension is what you want to look for. Sorry, we need to do this again.
Yeah, we really should. There are a lot of questions coming.
Yeah. So
Can we take one last, or you should go, right?
I know I have a
Can you?
but let's do let's, like I said, on July 7th on Friday, I have more time and then we can have a longer.
Yeah. Yeah, we'll do another one. So SLPs, we see your questions. We will answer them. We will keep them in mind and answer them the next time.
Okay.
I want to say thank you so much, Christina, for having you. It was a pleasure, and it was so informative, and I personally learned a lot. So thank you, and thank you for all the SLPs who were with us. Thank you for tuning in, and see you. Thank you.
I'll see you again.
Bye.
Bye.
Yeah. Bye.
Bye.